ABL-class fusions are rearrangements that involve the ABL1 gene, the ABL2 gene, PGFR beta or CSF1R in acute lymphoblastic leukemia. They form a network of gene fusions that underpin some, but not all of the patients with the BCR-ABL-like gene expression profile. Many studies in the past have shown that these patients have a high risk of relapse and also high levels of MRD at the end of induction. Crucially, because they have the involvement of these ABL-class genes, the functional consequence of these gene fusions is very similar to that of BCR-ABL itself. And hence, these patients are sensitive to treatment with tyrosine kinase inhibitors such as imatinib. Although previous reports have demonstrated efficacy of this drug in particular patients, there has been no direct comparison of patients with ABL-class fusions treated with and without imatinib. So in UKALL2011, we started screening for patients with high levels of MRD, that was more than 1% at the end of induction, for ABL-class fusions. And when we found them to be positive, imatinib was added to their frontline therapy. So in all cases, patients were screened at the end of induction. But because we introduced this screening strategy about halfway through UKALL2011, at the end of 2011, we ended up with two cohorts of patients, one which had received imatinib at the end of induction and one which hadn't. So it provided the opportunity to compare the outcome of these two cohorts of patients. So I should clarify here that the only patients that we screened were those that had MRD levels of more than 1% at the end of induction. And amongst all those patients, we found that ABL-class fusions accounted for around 11 to 13% of both B-cell precursor and TALL. In total, we identified 21 patients with ABL-class fusion. So this is still overall quite a rare abnormality. The most common fusion, as expected, was EBF1 PGFR beta, although we did find a range of fusions involving all four of the ABL-class hub genes. Importantly, there were two groups of patients. There were 13 patients that had been screened prospectively. The ABL-class fusion had been detected in and around the end of induction, and tyrosine kinase inhibitor, always imatinib, was administered in first remission, usually about 2 weeks after the end of induction. The second control group, who did not receive imatinib in first remission, accounted for around 8%, 8 patients overall. When we compared the outcome of these two patients that were representative and comparable in terms of sex, median age, white cell count, and also T-cell status, we found that both cohorts of patients had high levels of MRD at the end of induction, and they were comparable. They were way over the 1% threshold that we use for screening, and the median was about 20%. Looking at the outcome, we found that in the patients that received tyrosine kinase inhibitor in first remission, there were no events. However, two of the patients had died from transplant-related mortality after a stem cell transplant. In contrast, in the control group, 6 of the 8 patients had an event. These were either relapses or continuing refractory disease. And 4 patients have unfortunately gone on to die. Interestingly, 3 patients did receive a TKI after first relapse, but 2 of these 3 patients subsequently died. Therefore, the overall conclusion of this study was that this adds a huge amount of evidence that patients with an ABL-class fusion who have high levels of MRD do benefit from therapy with a tyrosine kinase inhibitor. One of the caveats of our study are that the numbers are relatively small, but these are rare patients. The follow-up time was modest, and also they had variable additional consolidation therapy. However, overall, we believe that ABL-class fusion patients do benefit from tyrosine kinase therapy. In our next trial, which will be a pan-European trial called ALTOGETHER-01, all children under the age of 16 with an ABL-class fusion will receive imatinib during induction at day 50. looking for the opportunity to decrease the high levels of MRD that we see in these patients at the end of induction.